We're going to talk about the new pacemaker, the external pacemaker, Medtronic's model 5392. This device has been enhanced with new features and some specific characteristics. And in today's session, which is about 30 to 40 minutes, we're going to cover all the aspects of the operation of this device. I'm going to go over to the device and show you the device from the outside first, and we're going to talk about some of the features and the menus afterwards. So this device, as you can see, is covered with a plastic cover. This hard cover is single use, and just to remove the hard case, there's a little tongue over here. You can flip this, and it removes the cover from the device. The device from the outside, we're going to go over some of the buttons and the screens. So the top screen is for the basic parameters. Those are rate and output. Each parameter has its own dedicated knob, which you can reprogram that parameter using the knob. This is the on and off button. We're going to talk about that and how you use that device, button to turn off the device. This is the emergency DOO button. This is the lock button and unlock at the same time. So if you wish to lock the screen and the buttons or unlock it, you use the same key. This is the enter button, and you will see this icon on the screen as well. And whenever you see that icon on the screen, that means you have to press this button, and we're going to cover that. These are just navigational cursors, so it takes you from one end of the screen to the other, and this only applies to the bottom screen. Any parameter on the bottom screen, if you wish to reprogram it, you use this knob, and we're going to cover that as well. This is the button that you can use to inhibit pacing or pause the pacemaker. On the top, you get the two connectors for the cables, and we're going to show you how to connect and disconnect the cables. Each of these, as you can see, are labeled with the letter A or V, atrium or ventricle, and they're also color-coded, blue for atrium, white for the ventricle, and we're going to talk about that as well. On the back of the device, you would see that there is a hook, this goes to the IV pole if you want to use this for managing the device on an IV pole. And the battery compartment for this device is at the bottom, and again, we're going to cover that in more detail. So to pop it out, there's this button, you press it, it pops out, and like I said, we're going to cover that aspect of it as well. So this was the device from the outside, and we're going to now turn the device on and go through some of the features step by step. Actually, before I turn the device on, let me just show you the cables that comes with this device. So each of these devices come with two cables. One is blue, as you can see, for the atrium. The other one is white for the ventricle. The connectors have a lock-in mechanism, so you just find the right port, push, you hear the click, and to unlock it, you basically press this button and push it out. So click and disconnect. Same thing goes with the A, and same thing goes with the V. Basically put it in, click, and take it out. Now, these two cables can be plugged into either of these two ports, and that's only in an emergency situation. So if you were in an emergency and you wanted to pace your patient, obviously you're not going to look for the blue cable if the only cable available is white, or vice versa. So they're both interchangeable from a connector perspective. We're going to talk about the maintenance of the cables and some of the other aspects towards the end of the talk. So I'm going to go ahead and turn the device on. So as I said, the power button up here, just you basically press this button to turn the device on, and the turning off feature is a little bit different. We're going to talk about that. So what I'm going to do is press the button and just hold it for a second. You'll notice that the device is now booting up, so to speak. It takes about 10 seconds to go through the startup process, and there's nothing I can do or you can do to expedite this process. So if you start playing with these buttons or the knobs, it's not going to get you there any faster. In fact, it might pause the device, and you have to take the battery out and reset the device in that case. So be patient during that 10 seconds of startup and let the device do its testing. It's for the safety of your patient and checking the device. So once the device shows you the parameters, that means it's ready to go and it's ready to operate. So like I said, the top screen has dedicated parameters. So each parameter has its own knob, and you only have 3 parameters. At the top, you can see the rate. So right now it's set at 80. That's the default value for this device. So when you turn it on, and every time you turn it on, you would see this rate set at 80. The atrial output, or as it says here, A output, is 10 milliamp. And this is the unit milliamp. And the V output, 10 milliamp also. So these are the 3 preset values that the device will always come on with those values. So you cannot pre-program the device, so to speak, to a different number for rate or output. And if you wish to change those numbers, you have to do it after the device starts up. You can see the range for each parameter on the side here. There's a little pie chart, if you will, that shows you the range for the rate. As you can see here, from 30 to 200 beats per minute, that's the range for programming the rate on this device. Atrial output, you can go from 0, meaning turning that channel off, all the way to 20 milliamp. And the ventricular output, you can go from 0 again to 25 milliamp. And obviously the ventricle might need a little bit more juice to capture the heart, so we give you a little bit more output in the V. At the very top of the screen, you can see there are lights flashing. Next to each light, it says pace or sense, and you can see each channel is separated. So this is the V channel, and this is the A channel. So right now in the A channel, I'm pacing, therefore the green light right above the pace letter, pace word. And here I see the green light again right above the pace. So that means A and V are both being paced. Obviously this is not connected to a patient, so there's no way for the device to recognize an intrinsic event. But if there was intrinsic activity recognized by the device, you can see that the other writing says sense. So the light that comes on here would be a blue colored light. So you either have green for paced or blue for sensed or intrinsic activity. So right across the room, you can look at the pacemaker screen and kind of tell, is it pacing, is it sensing, and what sort of rate and rhythm the patient has. Now, on the top, like I said, there's the rate, and right now is preset to 80 beats per minute. If I wish to change this parameter, I can use the dial knob over here. Right now, if I try to do it, it won't change anything. As you can see, it says the screen is locked. Notice if I didn't touch the screen for some time and the device locked itself. That timer is 1 minute. So if I don't do anything with this device and change anything, the device will lock itself after 1 minute. And if I try to change any of these parameters, I will get this message at the bottom screen. It says locked, press the key to unlock. So I'm going to press this to unlock the screen. So now both screens are viewable and all the keys over here are unlocked. So I can go ahead and change the rate. Notice I'm just dialing the knob, counter or counterclockwise, to increase or decrease the rate. I can go very fast, or I can just basically go very slow. Again, that's a simple turn knob operation. Same thing applies to the atrial output and the ventricular output. If you wish to increase the output, you go clockwise. If you wish to decrease the output, you go counterclockwise, and it does that. If I go counterclockwise all the way to 0, you will notice that the atrial channel is now off. What that means is the device is no longer delivering any output in the A, therefore the mode has changed to VVI. So originally I had the DDD mode, now it's changed to VVI if I turn the atrial channel off. This is probably the easiest way to change the mode from dual chamber operation to single chamber operation, going from DDD to VVI. Simply turn off the atrial channel. As soon as I turn back the atrial channel on, you'll notice it changes the mode to DDD. Whether or not this 0.1 milliamp is enough juice to capture the atrium, that's a different story. So I want to make sure that I increase my output to a level that I can see P waves on the screen or on the ECG screen. So you increase the output until you see capture in the atrium. Same thing applies exactly to the V output. So if I wanted to change the output in the V, I can increase the output. Let's say you don't see capture at 10. You increase it to 20, 21, and you can see capture and beyond. You can go all the way down to 0 again. This is counterclockwise turn. And at 0, the output turns off. And notice the mode now changed to AAI. So by turning off the V channel, I only have HL channel available, and the device is now working in AI. By the same token, if I change the output back up, even to 0.1, the device will go to DDD operation, which is dual chamber operation. So again, I want to make sure that I have capture, so I try to increase the output to a certain level that I can see capture on the ECG. So far on the top screen, what we've covered are 3 basic parameters: rate, atrial output, and ventricular output, and each have their own dedicated knobs, so it's pretty straightforward and nothing to guess for these parameters. The lights, as I said, will show you the operation of the pacemaker, whether it's pacing or sensing. At the bottom of the screen, we already kind of touched on this. You can see the mode. Right now the device is operating in DDD, so it's pacing both chambers, A and V, sensing both chambers, A and B, and it has the ability to trigger and inhibit pacing based on the settings. You can also see the battery meter right here, which shows you that this battery is obviously fairly new. So I can see 5 bars over here, and these bars indicate a full battery. As the battery is aging, these bars start to go away one by one and eventually down to the last bar. When the battery voltage is critically low, this whole icon would turn into a red light, and it's going to be a steady red light. I'm going to show you what that looks like in a few minutes. But if you see this light up, that means it's time to change the battery immediately. We'll talk about the battery longevity in a second as well. Now notice the device locked itself again, so I can see the lock icon here. So this is the 3rd icon you see at the bottom of the screen. And the lock icon is actually showing me that the device is locked and is pointing to this button. So it's pretty straightforward. It's telling you to press this button if you want to unlock. So this is what I did. I pressed that button. It did unlock the screen. I press it again. It's going to lock it again. So you can lock on demand by just pressing this button, which is the key button, or if you don't do anything with the device for 1 minute, it will lock itself after that time frame. Now, on the top, you have the on and off button. We're going to come back to that as well, and we have the DOO button. I'm going to demonstrate to you how that button works and what it does. So DOO emergency, it's a red button that you can see up top. And by pressing that button, the device is going to stay at the same rate. So let's say I change the rate to 90. And what it's going to do is crank up the output in the A and V to maximum. So this is in case you lost capture in any of the chambers and you're worried about patient safety, you simply press the DOO button. It tells you at the bottom screen, asynchronous pacing. The mode has changed to DOO, which is pacing the A, pacing the V, not sensing at all, and not responding to any sense events, obviously. So the device is pacing at the preset rate, or pre-programmed rate, I should say, 90 beats per minute, which is the last parameter that I programmed. And notice the output is now set to maximum both in the A and V. So the A and V are set to maximum output. So this is, like I said, again, in case you have a patient that is not capturing and you want to quickly gain capture, you press the DOO button. The device maximizes the output in both chambers. And if you're still not capturing by pressing the DOO button and on your ECG you don't see evidence of capture, then there's nothing this device can do to help you with in terms of pacing. So find other means of pacing, including external pacing. Now, as the device is operating in DOO because of this button, so the DOO emergency, it says asynchronous pacing going on, and it tells me to resume synchronous pacing, press, again, this button, which is the enter button. As you remember from earlier this session, I mentioned that the device will show you this icon, And every time you see this icon on the screen, you go ahead and press this button, which corresponds to that icon. So if I press the enter, the device is now switched mode to synchronous pacing or DDD pacing. However, notice that the output has not changed. The reason it doesn't change that is the device assumes you had a good reason pressing the DOO button, so it wants you to be in charge of changing the output as well. So you will be the one to decide if you want to reduce the output after going to synchronous pacing. So that part would not change back to previous values. So this concludes the top screen and the top area of the device and the buttons and all the keys that we have at our disposal. Now we're going to move down to the bottom screen. The bottom screen is predominantly for messaging. So any type of message will appear on the bottom screen. And you also have an extended menu here. So if I unlock the device, you'll notice there are several parameters here on the bottom screen. Up top, it says atrial sensitivity. Right below it, ventricular sensitivity, AV interval, upper rate, PVARP, A tracking, setting automatic, rapid atrial pacing, and mode selection. So right at the top, atrial sensitivity, you notice that there's a box around this parameter. This black box indicates the parameter that is highlighted. If I wanted to highlight a different parameter, I simply use the navigation buttons here. So if I wanted to go to AV interval, I have to do 1 and 2 clicks. Notice the box is now highlighting AV interval. If I wanted to go to PVARP, again, another 2, and the box is moving down with it. If I wanted to go back to V sensitivity, I go up 1, 2, and 3. The box is highlighting the V sensitivity. Whichever parameter is highlighted by this box is the parameter that you can change using this knob. So we'll start from the top. I'm going to go back to atrial sensitivity. So this indicates the sensitivity of the device to sensing intrinsic P waves. Right now is programmed to 0.5 millivolt. What that means is any atrial activity, namely the P waves, will be sensed by this device as long as the amplitude of that signal is above 0.5 millivolt. So if the amplitude of the P wave is less than 0.5, this device is not going to see it. If it's more than 0.5, it's going to see it. I can change that parameter by dialing up or down. So again, clockwise, counterclockwise. Notice as I'm going counterclockwise, this number is increasing. For sensitivity, the higher the number, the less sensitive the device is. So a good way of thinking of sensitivity is like a fence. The higher the fence, the less you see. The lower the fence, the more you see. So if I increase the height of the fence to 9.6 millivolt, that means that I can only see, so for in this example, I can only see P waves that are higher than 9.6 millivolt in amplitude, which is pretty high. So a typical P wave usually is around 2 millivolt or so. So in order to see that P wave properly, I have to lower the sensitivity to a number that I can sense the P wave. Now, the rule of thumb for programming sensitivity is wherever you start seeing the P waves, you cut that number in half. So if 1.6 was the starting point of seeing a P wave, then I will divide this number by 2 and leave it at, let's say, 0.5. So that means I at least have twice as much safety margin to sense the P wave. So I'm at 0.5. Let's say the P wave was a 1.6, because if I leave it at 1, which is the next value up, I don't have the 2 times safety margin. So if my P wave was 2 plus, I could have left it at 2 and still have that 2 times safety margin. So you pick the closest number that is smaller as your safety margin and leave it at that number. Same thing applies to the V sensitivity. So if I scroll down one box, so the box is now highlighting the V sensitivity. Right now I'm programmed to 2 millivolt. I can change this number. Notice it's going up or down. The same concept applies here. The lower the number, the more sensitive the device is. The higher the number, the less sensitive the device becomes. So if I'm at 6 millivolt as it is right now, that means the R wave amplitude has to be at least 6 millivolt for this device to see it. So if this was my least, the smallest number the device can see, by the same token, I can program the device to 3 millivolts to make sure I have at least twice as much safety margin. The reason we do apply the safety margin is that the amplitude of the intrinsic signals are not always consistently low or high. So you can see amplitudes going up or down, and this would account for that variation in amplitude and make sure that you can see even the smaller amplitudes in case they happen. So now I'm going to demonstrate to you that if I go all the way to the least sensitive value, now notice the device turned to async. So if I make it so insensitive that it's not going to see any physiologic signals, R waves and P waves, the device becomes asynchronous. Asynchronous meaning that it's not going to be sensing anything. Notice the mode has also changed to DOO. So it's only pacing the A and the V, D as in dual. It's not sensing A or V, and it's not responding to any signals because it's asynchronous. You probably also noticed that when I changed the V sensitivity to asynchronous, the A sensitivity became asynchronous as well. So the device cannot see one channel and not see the other. So it has to be either sensing both or not sensing either channel. So by just simply making it a little bit more sensitive, the device is going to go back to a DOO operation. Now it's going to sense based on this setting as long as the R wave is above 12 millivolts. So if that's not good enough, I can lower the output or the amplitude, to 7, 6, 5, or whatever number that we see suitable for that patient. So as soon as I change this number back, notice this went back to where it was. I could have done the same thing with the A. So if I go asynchronous in the A chamber, the V becomes asynchronous as well. So now, again, based on what we discussed earlier, when you change one channel to not sense anything, the other channel automatically stops sensing as well. So if I just go a little bit up, making it a little bit more sensitive, the device is now sensing both chambers. It's now in DDD mode again. Next parameter that we're going to talk about is the AV interval. Now, the AV interval, as the name suggests, is the interval between the A and the V. So every time the device senses a P wave or paces in the A, it starts this interval. So if the patient has sinus activity, every P wave is going to trigger an AV interval timer, and after this amount of time, it's going to pace the ventricle provided there's no intrinsic activity in the V. In other words, if the atrial activity, paced or sensed, conducts to the ventricle, and you can see a conducted QRS, this will not apply because the device has seen a V-sense, which is a sensed ventricular event, and it's going to inhibit pacing the V. So the AV interval would not apply. Notice the device locked itself, so I just pressed unlock to bring it back. So this AV interval is adjusted based on your patient. So obviously, if your patient has a short AV interval or a long AV interval, you can adjust this accordingly. So a long AV interval means that the patient is going to get paced more frequently. A shorter AV interval means that the patient is going to get paced less frequently. This is PR interval, sorry. If I change the AV interval to a shorter number, so let's say I go to AV interval and go to 90 milliseconds. That means the device is going to pace let's leave it at 100. The device is going to pace at 100 milliseconds in the V if there's no ventricular activity. So you pace or sense the A, the device waits for 100 milliseconds. If there is no intrinsic activity, paces the V. So if I wanted to promote intrinsic conduction, in this case, I would increase this number to beyond the patient's PR interval. Let's say the patient's PR interval was 170. I just program this to 200 milliseconds. In this case, the device will pace the A, for example, and then waits for 200 milliseconds before it paces. An intrinsic conduction is occurring, so the device sees the intrinsic conduction, so it's not going to pace. So again, if I wanted to force pace, I have to shorten this lower than the patient's PR interval. So that's how you program the AV interval. The next parameter is the upper rate. So upper rate is a parameter for the dual chamber operation, and essentially tells the device how fast it can pace in response to an intrinsic atrial activity. In other words, every time the patient has sinus activity, the device could potentially pace and follow that sinus activity up to this rate. So with this setting of lower rate of 90, upper rate of 120, if this patient's sinus activity increases from 90 to 100, the device is going to pace at 100. Now, this number is not going to change. It's just going to vary between these two ranges. And it will go all the way to 120. Now, obviously, for pediatric population, 120 is not a fast rate, so you can simply increase this rate to a number that is more comfortable for your patient. Notice that there's a message here that shows you that 2-to-1 block could happen. And we're just going to press here to take it away. We'll talk about that as well. So let's say at 155, that means this device has the capability to pace up to 155 beats per minute in the V in response to intrinsic atrial activity. If you wanted to, this number to go a little bit higher, so you have to pre-program some of the other parameters. For example, if my AV interval is too long, that's going to limit my upper rate. So I have to make this a little shorter to allow for a faster upper tracking rate. So by making my AV interval shorter, I can go a little bit faster on my AV, on my upper rate. So again, I reached the 2-to-1 block point. If I wanted to give it a little bit more space, I have to go back and either shorten the AV delay or pre-program the PVARP to a lower number, and we're going to talk about that as well. So these three parameters, AV interval, upper rate, and PVARP, work together to provide you with the patient's upper rate behavior, so to speak. So if you wanted to maintain a faster ventricular rate pacing, you have to pre-program some of these parameters to shorter numbers. So the sum of PVARP and AV interval gives you TARP, which is the total atrial refractory period. And during the atrial refractory period, obviously, you cannot track. So if you wanted to make the device track, you have to shorten that total atrial refractory period. And obviously, to shorten that total time, you have to shorten them individually or together. So these are the two parameters that you have to program in order to get a faster upper rate. Moving to PVARP, as we discussed earlier, this is one of the three parameters involved in upper rate behavior. So PVARP stands for post-ventricular atrial refractory period, PVARP. So it's the time that the atrium is in refractory from a pacemaker perspective. And during this time, any atrial activity would be regarded as an atrial refractory event. Atrial refractory events do not initiate AV interval. So for the AV interval to be initiated, you need a sensed atrial event or an intrinsic P wave that is outside refractory. So if it falls inside the refractory, it's not going to initiate a timer. Some of the common signals that might fall into PVARP are, for example, retrograde P waves. So if you had a ventricular activity followed shortly by a retrograde P wave, hopefully this interval here is going to cover that retrograde P wave to give you an atrial refractory event. And like I said, if it's atrial refractory, it's not going to initiate an AV interval. Now, a potential issue if you sense the retrograde P wave is that the pacemaker is going to go into the so-called pacemaker-mediated tachycardia. So if there is an intrinsic P wave out of nowhere, which is in this case a retrograde P wave, and the device sees it outside refractory, this could trigger a V event or a V pace, and that V pace could in turn trigger another retrograde P wave, and then it becomes a tachycardia. So every V creates a retrograde P. Every retrograde P is going to be tracked faster by the device. So now it's kind of like a dog chasing its own tail, and the device will go into a pacemaker tachycardia mode. So to prevent that from happening, you have to have a long enough P-VARP that covers any sort of retrograde P wave. And the extension of this P-VARP should be as long as possible to cover the retrograde conduction. Now, this nominal value for this number is 300 milliseconds, which is usually sufficient for adult population. For a pediatric population, you might have to lower this number, again, to allow for a faster upper tracking rate in combination with a shorter AV delay in most cases. So for pediatric population, you probably have to reprogram these two numbers individually to allow for a faster upper track rate. You don't want the P-VARP to be too short either, because if you go too short on the P-VARP, like I said earlier, you would be at risk of sensing retrograde P waves outside refractory. Therefore, the device will consider that a P wave and start tracking it and cause some sort of a tachycardia. So maintain a fairly decent number for that. Typically, less than 200 milliseconds might not be an ideal setting. The next parameter down is atrial tracking. So as the name suggests, the V is going to track the A. So atrial tracking is a term used for the pacemaker when the ventricle is pacing in response to an atrial event, sensed event. So you get an A sense, which is an intrinsic P wave. The device is going to follow that up to this rate, which is upper tracking rate, and it's going to track that. What happens if we go beyond the upper tracking rate? The device is going to start missing some of these signals to follow. So what I mean by that, let's say your atrial rate is, in this case, we have an upper tracking rate of 170. If the patient's intrinsic atrial rate or sinus rate goes to 190, that means you have 20 extra beats or extra P waves that the device cannot follow. Remember, it will cap the pacing rate at 170, so there's 20 P waves in between that the device cannot follow. So what happens to those 20 P waves? The device is going to time it as such that this 20 P waves are going to be dropped over 1 minute. In other words, every 3 seconds, the device is going to drop 1 P wave. And if that P wave, the only way to drop that P wave is to extend the AV delay little by little until it covers the P wave by pushing the P-VARP and therefore causing a pacemaker Winkelbach operation. So similar to the heart, that the PR interval extends until you have a dropped P wave. The pacemaker does exactly the same thing. In this case, extends the AV delay until one of the P waves fall into refractory and is dropped. So those 20 extra P waves that the device could not follow would be dropped in a Winkelbach operation. If the patient's intrinsic rate goes to, let's say, 200 beats per minute, then you have 30 extra P waves to drop. In this case, every 2 seconds, the device has to do the pacemaker Winkelbach operation, meaning the extension of the AV delay would be more aggressive. Nonetheless, it extends the AV delay to drop a P wave. Now, when would you not want the atrial tracking feature on? Let's say your patient comes to you in atrial fibrillation. Obviously, you do not want to track the atrial fib waves because they're fast and disorganized, And even in that case, the device will only follow it up to 170 beats per minute, but the patient will get stuck at a rate of 170. So if I turn atrial tracking off, and again, notice that parameter was highlighted, and I'm simply using the dial button here. So every time I want to change the parameter, I can dial. Because this is an on and off function, I can go either way, clockwise or counterclockwise. So if I turn the atrial tracking off, what this does to the pacemaker is that the device will stop tracking the intrinsic activity in the A. So any sort of P waves or fib waves or flutter waves for that matter would not be tracked by the device. The mode becomes DDI. What that means is it's going to be able to pace both A and B, sense both A and B, but only inhibit. So the trigger function of the pacemaker goes away, and that trigger function applies to an A sense to a V pace event. So you got a sensed P wave. There's never going to be a V pace following that because the device is not tracking that. So what happens is the V rate is going to be based on lower rate, and the A rate is going to be whatever the A rate is. So if the patient goes into atrial fibrillation at 250 beats per minute with the atrial tracking off, it's going to pace the V at a rate of 90 beats per minute, and the A is doing is in fibrillation. If I wanted to go back to a tracking mode, meaning enable the device to follow the intrinsic atrial activity, I simply highlight atrial tracking and turn it on. Speaking of this, if your patient has paroxysmal atrial fibrillation, meaning going in and out of AFib, and you don't want to limit the device operation, you want to benefit from DDD operation when the patient is in sinus, and you want to limit the tracking when the patient is in atrial fibrillation or flutter, this particular device and this particular model has a so-called mode switch option. And what that means is the device will detect fast atrial rates, and if the atrial rate becomes very fast, the device will stop tracking the A, knowing that the patient has gone into atrial fibrillation. Now, the other setting is manual versus automatic. Notice right now is in manual, and it's got an asterisk next to it. The reason it's in manual because remember earlier I started changing some of these parameters. As soon as you change one of the three high upper rate parameters, AV interval, upper rate, or PVARP, this is going to change to manual. I can maintain one or the other in automatic and change some of it in manual in that case, and I'll show you how to do that. So when is manual beneficial? Manual is in a case that you want to basically tailor the parameters to your patient, and mostly for pediatric population, you'll probably end up with customized parameters, so this would be manual. If I leave this in auto mode, what happens is whenever I change the rate, these three parameters adjust themselves based on rate. So in other words, if I lower the rate, notice that the AV delay is changing, and the PVARP is also changing. If I increase the rate, notice the AV delay is shortening, and now the upper rate is increasing. So the device is automatically giving you a fast rate in the a fast tracking rate, upper rate. So it's going to 194. So if I increase the rate, the device is adjusting the upper rate and it's shortening the AV interval. So this is the automatic mode. So every time you change the rate, some of these parameters or more than one of these parameters will adjust themselves to meet that demand rate. But again, if you don't want to be in an automatic function mode, you just turn it to manual, and now you have control over all these. So in this example, I'm just going to shorten the AV delay to 100. And if I start changing the rate, notice that AV delay stays at 100. So again, I made the device go into a potential 2-to-1 block mode, so the device was showing you that message on the screen. So every time you see that potential 2-to-1 block mode, 2-to-1 block message, You simply have to change some of these parameters to make the device or enable the device to track a faster rate based on these settings. So I'm just going to go ahead and change this to automatic again. Notice again, because it's a automatic manual, I can go either counterclock or clockwise and change the parameter. So far, as you saw, we can just navigate up and down on the menu, highlight the parameter that we want, and simply program the parameter and leave it at the desired value. So the next parameter on the bottom screen is rapid atrial pacing. So as the name suggests, the device is now able to pace the A really, really fast. And how fast is that? We'll get to that in a second. Notice again, it shows you the icon for the enter button. So it's asking you to press enter. So I simply press enter to get to that screen. In the screen, I can see the rapid atrial pacing is on. It's not on yet, but this is the menu. I can set the rate right here. It can go all the way to 800 beats per minute. Right now it's set to 250 beats per minute. Notice it's not pacing at that rate because I can see from the lights up here that it's still pacing at 90 plus beats per minute. So if I wanted to deliver rapid atrial pacing, I can go ahead and press enter because it says here, hold enter to deliver rapid atrial pacing. Now, I have to adjust the rate first based on the patient's rate. So when do you use rapid atrial pacing? One of the common scenarios that you might use that is if a patient is in atrial flutter. So there's a chance that you can overdrive that rate by pacing the A and hopefully put in the atrial tissue in refractory so the next flutter wave will catch onto refractory and basically stop the flutter. Now, in order to do that, you have to obviously be faster than the flutter rate. So if my flutter rate, let's say it's 250, if I wanted to pace at 245, that's not going to be sufficient because I'm pacing the heart slower than the intrinsic activity that is running right now. So in order to have a chance at terminating the flutter, I want to go a little bit faster than that. Let's say 10% faster than 250. That would be 275, so I'll leave it at 280, 270, something somewhere around there, and give it a try. So let's say at 270 beats per minute, I'm ready to deliver the ATP, and all I got to do is press and hold this button. So notice if I press it, it's not going to do the trick. It's just going to come back to the DDD mode. I have to press and hold the button. As I'm pressing and holding this button, notice the mode here says RAP, rapid atrial pacing. The light up here is flashing really, really fast, showing you that the atrial rate is going at that rate, in this case 275 beats per minute. And this color, the color on this screen has inverted. So these are the three indications that tells you, okay, I'm pacing the A really, really fast. And also notice the output is maximum. As soon as I let go of this button, it will resume pacing at the program parameters. Now, let me just lower the output here and deliver again. So notice at whatever output I have, it's going to deliver the rapid atrial pacing. So if you think you need a higher output, you have to adjust it accordingly. So I let go of that button, it goes back to normal pacemaker operation. If I wanted to get out of this screen, I can either leave it alone after the 1 minute time that it locks itself, it goes out, or I can navigate to the back button up here, down here. So as soon as I navigate down, it falls onto the back text over here, and it shows me that I have to press enter to get out. So if I press enter, it's going to go back to the main menu. There's also another way that you can do that, and for that matter, you can do it in any menu. So let's say you're in rapid atrial pacing menu, and you just want to get out. A quick way of doing it is just lock and unlocking the screen. Instead of finding the back, pressing enter, in 2 or 3 steps back. After that, going to the screen, you can simply lock and unlock, and it always brings you back to the home screen, so to speak. So you always get back to the screen. I'm going to go ahead and demonstrate to you the last parameter down here, which is mode selection. I can either click all the way down, get to mode selection, or I could have simply clicked one up, so it drops me down. So notice this is a scrolling menu, so I can go from the top to the bottom or bottom to top by one click. So I'm at the bottom of the screen, mode selection. Again, it's showing me to press enter to select the mode. So I'm going to press enter. Now it gives me the options that I have with this device: DDD, DDI, DOO, AAI, AOO, VVI, VOO, and OOO. So dual chamber operation, tracking, non-tracking, asynchronous, single chamber operation in the A, AAI, and asynchronous, single chamber operation in the V, VVI, and asynchronous, and essentially no pacing, which is OOO. It's no pacing, no sensing, no response. So that's the OOO function. So let's say I wanted to program the device to VVI. I'm going to go ahead and highlight VVI, and it tells me to press enter. I'm going to press enter. The device is going to switch to VVI. If I wanted to change the mode back, I can do it in a couple of ways, and we're going to talk about that. But before I go there, notice when I'm in VVI, the menu on the bottom screen has adjusted itself to VVI parameters only. So none of the atrial parameters and high rate parameters are showing on the screen. All you see is ventricular sensitivity, which I can adjust, make it more sensitive, less sensitive. I can still do the rapid atrial pacing, and I can still change the mode. So if I wanted to change the mode back to DDD, I can highlight DDD and press enter. Now it's back to DDD. Another way of doing that was, let's say I was in VVI and I wanted to go to DDD. Remember earlier in the session, the atrial output is off. All I got to do is turn the atrial output on to any value above 0, but hopefully you want to maintain capture, so you'll kind of set a number that is appropriate for capturing the A. And notice now it goes to DDD. If I wanted to go back to VVI, I simply turn the atrial output off to 0, and it's back in VVI. So a quick way of changing the mode is not going through the mode selection screen, but simply changing the output. Let's say I wanted to go DOO. All I got to do is make the atrial or the ventricular sensitivity asynchronous. So if I go asynchronous in the A, remember the V becomes asynchronous as well. Now the mode shows DOO or asynchronous dual chamber pacing. So as you can see, there are a number of ways that you can reprogram the device mode. One way is obviously go through mode selection and just select the mode that you like. And there are shortcuts by using other buttons and changing some parameters. Now, I'm just going to go ahead and go back to DDD again. So this covers all the items in the bottom menu as well. So remember, the bottom menu is for extended parameters, A sensitivity, V sensitivity, AV interval, upper rate, PVARP, atrial tracking on or off, automatic setting versus manual, and rapid atrial pacing, and at the bottom of the screen, mode selection. And the top screen, just to review quickly, you only have 3 parameters, 3 dial knobs, and each are dedicated to each parameter. So if I wanted to change the atrial output, ventricular output, I have my own knob. So I do have the same knob. I have a knob for the rate as well. Now, we've covered all the buttons so far except the power button and the pause button. So I'm going to start with the pause button before I turn the device off. So let's say for whatever reason you want to pause the pacemaker to look at the patient's intrinsic activity and see what underlying rhythm the patient has. So all you got to do is press and hold this button. So this pause button looks like a pause icon on your VCR as well. You pause. It says caution, pacing is suspended. Obviously, notice that there are no lights up there. So if I press pause and hold, see the lights are gone up here. If I let it go, come back. So I can press and hold the pause button. It's not pacing at all, but there is a time limit for the pause button. If I press this longer than 10 seconds, the device will come back on pacing, as it did right now. So the timer that applies to pause is 10 seconds, whether I hold this button or not. So again, I'm pressing pause, I'm holding it, in 5, 4, 3, 2, 1. It's going to go on pacing pretty soon. There you go. And now, even though I'm holding the button, it went on pacing. So there is a safety feature in the background that does not let you pause more than 10 seconds. So if you want it to pause more than 10 seconds, you have to let it go, press again, let it go, press again. So this covers all the buttons except the power button, and I'm going to go to demonstrate to you how to turn the device off. So in order to turn the device off, you simply press the off button. As a safety feature, the device is not going to turn off. Rather, it's going to ask you that, are you sure you want to turn the device off? And if so, caution, all pacing will be stopped. And if you're comfortable with that, press enter, and notice the icon is here, to turn it off. If you don't want to turn it off, you want to go back, you simply go back. Now, if I wanted to turn the device off, I press the enter button to confirm that I want to turn the device off. And now the device is immediately shut down. So there's no way to get back or abort the process. The only way is to turn the device back on so you can get pacing. Now, in order to turn the device back on, remember initially I pressed and hold the power button to turn it on. There is another way to turn the device on, and that's using the DOO button up here. So if I press and hold the DOO button, similar to the power button, it's going to come on as DOO maximum output. So this is in case you have an emergency, you're not sure what the patient's thresholds are in the A or V, and you just want to turn the device on, ensuring that you have maximum output. So I press the DOO, goes through the cycle, the 10-second cycle, that's the boot up cycle, starting up, and there you go. It's pacing at 80 beats per minute. This does not change. Notice the output is maximum because I turned it on using DOO. In order to go back to synchronous pacing, I have to press enter, and now I'm back to synchronous, so DDD, but notice the output is not changed. So if I wanted to change the output, I have to do it manually on command. So that's how you turn the device off and on. So I'm going to demonstrate to you one more time how to turn the device off, press the power button, and then confirm it with enter. So a two-step process. Now, as I'm turning the device on, this is the only way I can demonstrate to you the red battery meter that I mentioned earlier that comes on. So notice in the middle of the top screen, you have the battery meter. You can see shades of it right here. If the battery level is low, a critically low value, this icon lights up as red. So the only way I can show it to you is that during the startup, it also lights up as red. Notice here. So this is what you're going to see if the battery is critically low. Obviously, it's not going to go away if the battery is low, but if the battery is fine, it's going to go away and just show you the meter. And remember, these bars start to go away one by one. Now, speaking of battery, a typical life of a battery in this device is at least 1 week. So once you put in a new battery in this device, and that battery is within spec, which is a AA battery, and the LR6 type battery, this device is going to operate for at least a week based on the settings. Obviously, if you change the rate to a faster rate or change the output to to higher output, you get less longevity. If your rates are lower output, you get more longevity with the same battery. Medtronic's recommendation with changing the battery is every new patient, you get a new battery, you put in a new battery, but every hospital has their own policies with regards to changing the battery as well. So you follow your own hospital policy with that regard. But the good news is that you can always manage the battery longevity just using this icon. You always look at this icon, see where you are with the battery life of this device or of this of the battery, and simply make a decision to change it before you hook up the patient or after that. Now, speaking of changing the battery, I'm just going to demonstrate to you how you can do that. Notice the device is operating and still on, and what I'm going to do is try to change the battery as the device is on. So in order to do so, I have to obviously open the compartment. To open the battery compartment, I have to press the lock button here to release the tray. So this is the battery tray. Notice it stopped halfway through. That's a safety feature. It's got a little latch here that holds on to the tray so it doesn't come all the way out. If I wanted to pull it all the way out, all I got to do is lift this slightly and pull it out. So if I show it to you from this angle, simply lift it up and it comes out. In this position, you can remove the batteries. And in the battery tray, you'll notice that you got a picture that shows you how to put the battery in, positive and positive. It shows you that's an AA LR6 1.5 volt battery. And in the device manual, there are detailed specs of that battery. So obviously, because it's a AA, it's important to put the battery in the right way. So make sure that the positive is lined up with the positive and before you put it in. Notice the device is still pacing. So even though I don't have a battery in the device, it's still pacing and the operation is ongoing with the same parameters. This light is flashing red. This indicates that there is no power source. So for me to make this go away, I have to quickly replace the batteries. So if I put the batteries back in the way it was intended, it should go away. So what I'm going to do is put it in the other way around. So I put it in upside down. Notice that because I didn't put it in right, it's still showing you that it's flashing red. So the operation, the battery is still requiring us to replace it. So I'm going to remove the battery. This time I'm going to place it in properly, negative to negative, positive to positive. And I'm going to close the lid. And as soon as I do this the right way, notice the battery meter is now showing me full 5 bar, which indicates the battery is new. And the light is no longer flashing and everything is happy. As I was changing the battery, you notice that the operation was still ongoing. We guarantee a 30-second operation without the battery in the tray. That should give you sufficient time to change the battery in an emergency situation, although we do not recommend you doing this as a routine procedure. So do not wait for the battery to basically start flashing red and then when it's hooked up to a patient, start changing that, although the window is there. So we do not recommend that. But if you're in a situation that you have to absolutely do that, yes, you can. You can open the battery, it starts to flash red. You got 30 seconds to change the battery. In a case like that, obviously you want to make sure that you have your batteries handy, unwrapped from the shrink wrap or whatever box they may come in, and get them ready before you open this latch. You simply take the batteries out and replace them with a new battery. Again, look at the picture inside here, make sure the positive and negative poles are properly aligned, and simply close the door. Notice as I'm closing the door, if I don't close it properly, it's still showing me that it's in, but this could easily pop out and again, the battery operation would be compromised. So you make sure you press it all the way in and hear the click. Again, the click. Once it clicks, everything should be flushed here. So that means that the tray is properly closed and the light goes away and you're ready for pacemaker operation using this device. So this covers the battery compartment and also changing the battery as well. We already talked about the connections of the cables. Now I'm going to talk about the basic maintenance of the device. This device can only be cleaned with alcohol solution. So you cannot use any sort of solution that contains ether, acetone, or peroxide. This includes some of the popular wipes that some hospitals use. And so we do not want you to use those wipes. The only wipes that you're allowed to use are alcohol-based, isopropyl 70%. There are commercially available wipes that give you that capability, so you do use that. So as an example, Viroxin is not to be used on this device. The reason we say that is the resin for this compartment and also the screen of the device is sensitive to any sort of peroxide or acetone and ether that I mentioned. And over time, you're going to see miniaturized cracks on the device, or you might not even see it, and that prevents the device from being properly cleaned. So because of the pores or the cracks that are created, germs will get into those cracks and cannot be cleaned. And the problem with the screen over time is going to be that it's going to be so hazy and so dull that you can barely see the parameters underneath it. So it kind of will look, again, I'm just trying to reflect the light on the screen to show you how it could become over time. But again, you probably won't see a clear view of the parameters if the non-alcohol solutions are used. So only alcohol-based solutions, 70% isopropyl would be sufficient for this device. Now, this device, although it's resistant or been tested for drops, we do not obviously recommend you to drop this device, but if it does fall down, it'll probably have some sort of a resistance to that, and it's not going to be broken right away. However, every time this device falls, you have to have it tested and looked after by the biomed department. So any fall greater than a foot or a couple of feet, you want to make sure that it's tested. Even in that case, I would have it tested. So once biomed gets a chance to look at the device and verify the operation, you can reuse it. So if you drop the device on the floor, try not to use it on the patient, replace it with another device, and send that device back to biomed. Same thing applies to any sort of fluid spills. This device is not water resistant, but it's spill proof or spill resistant. So what that means is if you have fluid spill over the device, it's going to resist the leakage inside the device to a certain extent. So it's not like it's a waterproof again. If you drop it in a bucket of water, it's probably going to damage the device, but it's going to withstand some minor spills. If any spills happens on this device, you make sure that, again, you send it back for testing to biomed. And once everything checks out by biomed, you can start using the device back again. And as far as cable connection, again, if you have any sort of problems with the cable, you might see loss of output, you might see loss of sensing, so test the cables ahead of time. And if you see any problems, obviously you don't use the cables. And these are compatible with the 5388 cables. So if you have cables from the previous models or the previous devices, they, as long as they're the same model, 5388, it could fit to this device. And again, that could be verified through biomed. And so this concludes the session about the maintenance and the operation of the device. I'm just going to show you again this lid that we showed you initially. The only purpose we have for this lid is obviously, other than protecting the screen and the device, is that this DOO button up here is not going to be locked even if the device is locked. So notice the device is in locked position. I can still press the DOO and get the DOO operation. This is obviously a safety feature because even if you're locked, you might need the device to pace at a higher output. You can trigger that using the DOO button. If you look from the side, there's a little dent over here that prevents you from accidentally pressing that button. So that is designed to prevent it from being pressed. But if somebody intentionally presses this button, obviously it works, whether it's you or your patient. So to prevent that from happening, you can always use this cover, and the cover simply goes and clicks on. And by having this cover, then it's not going to be possible to press the DOO button to get the operation. So that's a good way of protecting the device, as well as preventing accidental DOO operation by the device. And remember, if you press the DOO button to get back to synchronous pacing, you have to press the enter button. It goes back to DDD, but notice the output is not going to be adjusted. So I'm just going to have to manually adjust the output. Well, thank you very much, and this concludes the session with regards to the 5392 dual chamber and single chamber pacemaker made by Medtronic.